think I was just more. But...
Okay, go ahead. So some of the things that you have learned few months, it's been a month, right?
Since my externship, it's been maybe I finished my externship, I think in November.
Yes.
Oh, no, October, I think. In October, so
it's been a few months, so you're kind of we're out of touch, and that is why you've forgotten some of the materials that you had, right?
yeah.
I am recording this, so I'm going to send you back this recording so that what you can do when you have time, all these questions and answers that I'm going to go over right now, it will be there on the record. You can play it. I'm going to send the link to your email.
Okay.
That is what I'm doing for all the other students for Zoom. So that way, you don't have to really look it up right away. You can, do your things that you're doing at home. When you have time later in the evening or whenever you have time, maybe tomorrow, you can play the recording, and that way you can pause the recording, and anytime you want, write your notes whenever you want, and then restart. This way you can see what is happening, what mistakes you have made. Some of the mistakes that you have made are very difficult one. You're not going to get responsible for that. So there are 175 questions that you're going to get on the board exam, NBSTSA board exam. Out of that, you have to answer 105 questions correctly. So you have 70 questions that would be in a difficult range from moderate to really highly difficult. So those questions, we're not going to hold you responsible. It's the same setup here on the pre-test that you are seeing, that you have taken on March 24th. Exactly same type, same mock exam. So if you have scored 62% on this test, that will represent your scores around 65 to 66% on your test for the board.
Yeah.
So you would have, if you would have taken the board on that day, March 24th, you would have not succeeded. So you had to, you would have wasted your one attempt that you have free from the, that is the attempt that it's been paid for. You already paid for that. So it kind of saved you one whole attempt, give you a lifeline. So now you can look at this recording and you can go over with me, why do you feel, which answers that you picked, why you didn't like the other options that was available there. That way you can build your own bridge towards your success.
Yeah.
So you have all the materials that you've been getting from me slowly through the email and through the ST600 courses. You got all those materials, you have everything. Your materials you have, you don't need anything else. You also got the book, right? The handbooks. So you have 18 mock exams and answers for all 18, total 3,600 questions and answers. That is the question bank where those board exam comes from. You're prepared, your materials are prepared. It is when you're taking the test, you are rushing. I saw you finish this test, the pre-test, within hour and 15 minutes. You had 4 hours to take the test. You finished it very quickly. If you would have gone slow and take these phrases, separate them and look at it, these questions rather closely, you would have gotten to 70%, no doubt about it.
Yeah.
But let's go through this process now. The first question I see you did marked wrong is the question number 4, right here. Now you tell me, now you can look at it, now you're relaxed at home, nobody is putting pressure on you, there's no time. So now you can tell, which one do you think would be the right answer for question number 4? Break it down, each one of them. You have meninges, right? So brain has this covering, meninges. Meninges has pia matter that sits right next to the bone. That's the soft matter. Then you have a gap, which is the subarachnoid space. Then on top of that, pia matter, you have arachnoid matter. Then you have dura matter. So you have 3 layers. From top to bottom, you have dura, arachnoid, pia. Right? Like if I can write it right here, it'll be like this. Dura. Then next one is
The arachnoid.
arachnoid. And then the last one is pia. Now, the CSF is the fluid. That is the fluid comes out from the choroid plexus of the brain, and it circulates everywhere to send out, transport nutrients to the cells of the brain, and also it works. Brain and spinal cord have this fluid, so it can absorb tremendous amount of shock. So it kind of circulates the surrounding of the brain and spinal cord. Now, pia and brain, they're adjacent to each other. There is no space there. Now, arachnoid and pia, in between them, there is a space. Very little space, but there is a space. That space is called subarachnoid space. Okay, and that is where the CSF fluid usually stays. On top of that arachnoid matter, right next to that arachnoid matter, you have dura. Underneath that dura, you have some blood vessels, and you have some blood vessels above the dura. So your answer would be here, subarachnoid space would be the correct answer. Okay. But you have marked subdural space. I think you got confused there. Underneath the dura, if you go through that dura, you just feel there is bleeding there and arachnoid matter, but you won't get CSF. In order to get to the CSF, you have to go another layer down.
Yeah.
All right. So you will know that right now. You'll got it, checked out. So you know that.
Yes.
Next question is this 5. What do you think the hemoglobin do?
Um, so that's the thing. I think that's when I was started overthinking, because there was another question that reminded me of that one, but it was for something else. So
Okay.
hemoglobin, I don't, which answer did I even put for that one?
Hemoglobin is the red blood cell. So it is red because of oxygen, right? You're right. It sends out the oxygen to the cell. So B is the correct answer here. Carry oxygen to the cell.
I put carry lymphocyte, huh?
Okay, lymphocyte is the work for the WBC.
Yeah, for
white blood cell. Lymph is white. Lymphocyte is usually goes through its own channel. And whatever is left over, that goes through the WBC sometimes, but most of the lymph don't even go into the blood. Lymph node has its own, remember, lymph has, all the lymph node of thymus gland, mediastinum lymph nodes. They have their own passage. They have their channel for their own duct system, lymph duct. Through that, lymphocyte travels from axillary. Lymphocyte drains the lymph and all the lymph from the body and bring it back, dump it as a waste product through the lymph channel into the blood.
Yeah, because white blood cells, isn't that one, so if you get it, if you start bleeding, that one comes so that it could help you, what's it called, heal, I know it's something like that, so it will help you.
Phagocytosis. White blood cell does get rid of the bacteria, virus, or any foreign material. It engulfs. It does phagocytosis. Phago means engulfing or eating away. Cytosis is the root word, which is dissolving those cells. By eating the white blood cell eats those foreign cells. Whenever you have inflammation, you will have infection, you have foreign material inside the blood.
Yeah.
And phagocytosis, those white blood cell runs there and kind of circles, kind of envelopes those foreign material and eventually eats them. What happens is the foreign material goes inside of the phagocytosis, and then the phagocytosis actually become pus. That is how phagocytosis actually kills the foreign cells, and by doing that, phagocytosis itself got killed in that fighting. And then it becomes the pus. That is how we get the pus out of the infection.
Yeah.
The pus that you are seeing, that is the dead white blood cell, including the cell, the foreign material. So here, hemoglobin is the red blood cell.
Yeah.
So it does transport the oxygen to everywhere.
For that one, what was my answer?
Your answer was carry lymphocyte.
Yeah, I remember that.
Yeah, I think you got confused there. So the correct answer for this question would be D, B only. Right.
I remember that.
Next one would be eight. The outermost layer of the skin.
That one into the dermis?
Okay, what would be the topmost layer of the skin then? What is epidermis?
Isn't the epidermis beneath the dermis?
This is the word epi means below or above?
To me, I feel like it's below, but right now I'm thinking that it's gonna be above.
Okay, what is the word hypo? Hypo means Hypo.
That's low.
Below. So hypo is below. Epi is opposite of hypo, which is above.
Okay.
So,
So I mean,
the epidermis, which is above the dermis.
okay.
So outermost layer of the skin would be that thin layer of epidermis.
Okay.
Then underneath there, you have dermis, cutaneous and subcutaneous followed by that.
Okay.
Good. Okay. What is that little layer, the membrane that you get rid of when you expose the bone? You have an elevator. Remember the name of that elevator that you use? This is about question number 10. This is that elevator that you use to get rid of this layer from
It's
the bone. Remember that?
I remember how it looked.
Periosteal elevator.
Mm-hmm.
Remember using those periosteal elevators from the instruments tray, orthopedic or anything like plastic, because the bone has a layer, a thin layer. You have to get rid of that in order to get to the real bone.
Mm-hmm.
That layer is periosteum. So other things that you see, you mark peritoneum. Peritoneum, where do you find peritoneum?
It's not even in the bone, huh?
Yeah, peritoneum is the covering of the abdominal cavity.
I know.
Right, yeah. Okay. Average number of here. See, here you knew what our red blood cell is known as. In question number 11, you marked it right.
I know.
Red blood cell is known as hematocrit because it carries the oxygen. You marked this one right.
Yeah.
So you know which one is leukocyte and which one is W white blood cell and which two are the same as red blood cell. And you marked it right by marking hematocrit.
I know. It's because like I feel like I got confused with those two questions because since I seen it twice, I was like, oh, like that means there could only be one option for it. It's either hemoglobin or hematocrit. And I knew it was hematocrit. So I was thinking, what if hemoglobin has to do with something else? I was like maybe like it's protein, something. Like I started overthinking it.
Yes. Now, number 12. This is something we have to memorize. We don't know. There is no way of, giving you hints. Leukocytes are the white blood cell. Average is 1,000 to 4,000.
Mm-hmm.
You marked 4,000 to 10,000. So the correct answer would be 1,000 to 4,000.
Okay.
The pacemaker of the heart, which starts the electric conductivity, which is the pacemaker of the heart.
It's gonna be one of the. Is it B?
That is what you marked. It would be SA node or sinoatrial node. Please look up that one.
Okay.
That one is your heart anatomy.
Okay.
You have to look it up for your heart related questions. Now, this is also your anatomy, basic anatomy lab. About anterior, posterior, and ventral, dorsal. What is ventral in
I remember
anatomical?
I put posterior, but I think it's either anterior or inferior.
It would be anterior,
Yeah.
would be the answer. Ventral refers to the anterior part of the body.
Hmm.
Now, ABO blood grouping. Do you know which one do not have any antigen? And these are the universal donor. These groups, if you have this group, you can give blood, you can donate blood to anybody.
Oh, isn't it O?
Yes, it's O, but you actually marked A.
Yeah,
So
I think
no,
with the question.
yeah, okay, I got it. So A has antigen A. That is why
Yeah.
ABO, O has no antigen.
Yeah, I think I got confused with the question on that one.
Yes.
Because the way you asked it right now, I would have known it was O right away.
Yes, I understand very well. You knew the PRN, what is PRN stands for. Now, retro, what do you think retro means? This prefix, retro. Think about it this way: retro dress, retro design, retro, fashion. What do you think about when you think retro fashion? What does that mean? Like when somebody is wearing 1960s
Oh, backward or
dress,
behind.
backward, right?
Mm.
So you go backward. Not you you put behind. Behind is posterior.
Mm-hmm.
Retro is backward. Great.
Okay.
If you think about, when you see retro, think about retro fashion. Then you will remember retro would be going backward.
Okay.
Like Back to the Future.
Oh yeah.
Okay. Again, ventral, you had anterior position. Question number 20.
Mm-hmm.
In human, anterior position is same as you put inferior. What do you mean by anterior position? Think about your nose. Is nose anterior than your ear structure?
No.
Ear is backward, right? Ears is behind, right?
Yes.
So nose would be anterior, right?
Yes.
Like your kneecap would be anterior to your back side of the knee, right?
Yes.
So anterior would be the front area, ventral area.
Okay.
So that one you really have to know because you're becoming a surgical technologist. They will ask you question. You will see schedule like anterior thoracotomy. So that way you know the position would be anterior part of the chest wall, not the back side of the chest wall.
Mm-hmm.
So you can get stuff for your proper case. It could be like anterior abdominal wall versus posterior abdominal wall. So you
Mm-hmm.
know you have to turn the patient supine, face up, face to the ceiling, right? In order to get to the anterior part.
Mm-hmm.
For posterior abdominal cavity, you have to turn the patient prone, face
Yes.
down, so you can get to the come through the back side. So you have to know this anterior, posterior, inferior, superior, and ventral, dorsal, distal, and proximal. These six analogy you have to really keep it on your under your belt. You have to know them very, very well
Yeah.
because that is how the schedule will say. So you're going to pick a case for the day and it will say anterior, chest wall. Then
Mm-hmm.
how do you know which one is anterior chest wall? Okay, 21. This one you have to do it by your own. When you are kicking the directly, what is your thigh doing to the rest of the body?
Well, I mean, you're extending your leg if you're kicking directly.
Yeah, you are, that is correct, your leg, but I'm talking about thigh. Is your thigh coming close to your body?
Yes.
So what is happening? The angle in between thigh and the body is increasing or decreasing?
It would, well, you're bringing it together, so wouldn't it be adducted?
It will be flexed then, right? When the
Oh,
angle is
flat.
decreasing, then it will be flexed, right?
Mm-hmm.
Because when you flex your hand, the angle in between the wrist and the shoulder decreases, right?
Yes.
So you call it, yeah, I'm flexing my biceps tendon. Similarly, thigh has those muscle. They are attached to your pelvic girdle. And when you are kicking, your leg is extending, but your thigh is flexing.
Mm-hmm. Okay, I think I
That's
got.
what you have to kind of do it to, to understand. Like you have to really sit there and, okay, let me kick, see what happens, what is decreasing and which angle is increasing. That
Mm-hmm.
is how you find out about that.
Okay.
Asepsis. This is question number 23. Uh, 23 is about asepsis. What does that mean?
Is it the absence of infectious agents?
Exactly. That would be the correct response. Yeah, you got it now. You got it right now. You got it. All right.
Mm-hmm.
Now, the difficult one here, this first intention wound healing, this is very difficult question to answer, but you answered them all correctly. The rest of the rest of this page, you answer them all correctly. So you have memorized these difficult ones. Anesthesia, antagonist for heparin. You got all these difficult ones. Correct answer you provided. Very well. I'm really proud of you. Got all these the difficult ones. Got it right.
Mhm.
So what we understand so far is if you do your anatomy a little bit of brush up and do your anterior posterior the anatomical location little brush up, then so far you're going to be very good. Another thing about the Foley catheter checking, this one you have to do it when you are setting up Foley catheter. You have to do this checkup whether the Foley catheter is working or not. Now that you are relaxed, how would you do it when you had clinical? How did you check your Foley catheter or in the lab? First of all, let me ask you, when you had the lab during your lab rotation of 200 class, 300 class, and 400 class, did you actually get a chance to go into the lab or did you watch video?
No, I got a chance to go into the lab.
Okay, 200 and 300, did you get a chance to go to the lab?
Yes, but that was way before COVID started.
Yeah, that is when the COVID didn't hit. So
Yeah.
you had trouble after the COVID started, right?
Yeah, and then it was like a year later until I went to do my externship, and then at the hospital they never actually had us check the integrity of the Foley.
Yeah, so you didn't have to do this. Understand, those are the problem during the COVID. They didn't get a chance to do a lot of these clinical practice.
Mhm.
So here, what we do for the Foley catheter, we have to use, first of all, we have to use water. We don't use saline in there. Saline can cause dissipation of that the choroid, that balloon thing. So we don't use air, because if you use air, if there's a puncture of the air, then this is not going to be good inside that urinary bladder. And we don't use HIPIC. HIPIC is contrast media. We only use HIPIC in order to do X-ray, right?
Mhm.
So we use only water. Water is the only liquid that goes into the balloon to check the integrity of the balloon. Make sure you do that when you check
Okay.
Foley catheter. Okay. 33 is about legal ethical problem. 33 right here. You are transporting a patient. Now think about that. You are there transporting a patient. Now you're going to scrub. Now while you're transporting, the patient is telling you that he is going to die. What would you do? If
You
you
see,
have,
that question kind of, I feel like it was a little like confusing, because if the patient tells you you're gonna die, you can't really tell them like, oh, you're not gonna die, because if you can't really say that, you can't promise something that can't be, like you can't really promise anything to them. You could just say like, oh, like you're in the best treatment possible or something, but I don't know if that counts as consoling them. Or I mean, I have never heard of a like a time where somebody would call a priest, so I didn't think that would be necessary. And then as for the surgeon, yeah, he's responsible for the case, but like if he already did the surgery, and then they said that they think that the surgery went fine, I don't understand. I don't see why they would have to call the surgeon back, because that's just like the patient being scared. So, and then they're like, I was in between consoling them and telling a supervisor, but yet again, a supervisor is probably going to tell them the same thing, like, oh, you're in the best treatment possible. We're doing everything we can. So I didn't know what to answer there.
Got it. But in this case, for legal ethical standpoint, we always tell our student, and you will see the preceptor will also tell that if you have a option, only option available in between consoling them or informing the surgeon, you have to take the best option would be to inform the surgeon. That is his patient or her patient. He is the one has to consult the patient before the surgery. They have to stop. If that happens, when the patient tells that, oh, I'm going to die, then you have to call. If you're scrubbed, you break scrub and pick up the phone and let the front desk know to have the surgeon come into the room immediately. And you tell the surgeon, quote unquote, what the patient just told you. That is top priority. Nothing happens unless the patient and surgeon talks and surgeon can clear this fear out of the patient's mind. Anesthesia is not gonna go through the patient when the patient is telling he's thinking about dying, he's going to die. That's a very, very high priority. And your job, if you are the only one there, your job would be to inform the surgeon right away. That's your top priority. You don't tell anything. You tell that I'm going to talk to the surgeon. I'm going to tell the surgeon right now what you just told me, and stand by there. Use the intercom of the room. Inform the surgeon. Let him come and take care of it from there. Your job would be, top priority of your job would be to drop everything and quote unquote convey the message to the surgeon. Once you told the surgeon, your job is done. Then you can go on doing everything. Most likely, surgeon will consult with the patient, anesthesia will talk to the patient, and case will go forward. Very least likely, the case will be canceled. That happens quite often. Especially elderly people do that. This happened to me many, many times, more than 10 times at least, I can tell. Now, you have this. When you are number 37, this would be the biological indicator. That is the way you can tell that sterilization process has concluded and it killed all the spore forming ones. The old technique was you didn't have to put biological indicator. Now, new technique, you have to always put biological indicator for your autoclave.
Okay.
So its answer is A. Okay?
Okay.
All right. Question number 47. This one, I kind of explained everybody before the exam because I know people get confused. Here, you have this question, 47. Can you tell how much marking you need in order to make it so that you have a equal mixture?
I put 4 milliliters on that one.
Okay, I know, but how did you come up with 4 ml?
Because I remember we used that.
So you have 0.25% marking, and that means here, if we write down here, this is what you're gonna get line by line. 1 ml, right here is 1 ml, equal to 0.25%. We can put percent. 0.25%. Now the lidocaine you have 1 ml equal to, we can go back here. This is your marcaine and this is your lidocaine. We can put marcaine here on top, right down here, just mark see marking, and oh, not there. Lido, you have 1%, 1 full percent, right? 1 ml. Each ml contains 0.25% marcaine and 1% lidocaine. Now, in order to, oh, sorry, it's not 1%, it's 0.5%. Now, in order to make your marcaine 0.5%, how many milliliters you need?
2.
2, right? You just double it. So 1 equal 0.25. In order to get to 0.5, you just need to double it, right? So if you do it in a old type of math, let me show you how we used to do old math and never get wrong with that. The fraction that we do in the high school, we do it this way. I'm going to write it and I'm going to show you. So 1 ml equals 0.25%. In order to get to 2 ml, we're going to need 0.25% times 2, which is 0.5%. 2 ml will give you 0.5%. Right? So 25% has 1 ml. 1%, that's 0.25%. So in order to get full 1%, you're going to need
The
4
4.
ml, right?
Yes.
So in order to get to 0.5%,
You need 2.
you need 2 ml, right?
Yes.
So now if you break it down like that, it's easy. All you're doing, you're trying to get to this percentage here. So 1, you got 0.25, you add another ml, you get 0.5%. If you add another ml, you get 0.75%. If you add another ml, you get 2 ml, the whole 1%. So this is how you write. You have to write it down in order to do this. If you don't write it down, if you want to do it on your head, most likely you're going to get the incorrect answer. If you write it down, it stays right in front of you. You can do it. And this is something we have to do it at work. We always get lidocaine 1% and marcaine 0.5% or 1/4%.
Mhm.
And then we have to mix it together to make an equal solution.
I think-
Always lidocaine is higher percentile than the
Yeah.
marcaine. Usually we double it with 0.5% marcaine. We use 2 cc's of 0.5% marcaine and 1 cc's of 0.5% lidocaine, and we get it right there.
Yeah.
Okay, so this is something you have to do it at work. For local anesthetics, surgeon will ask you to mix it both.
Okay.
Right.
Yeah. Yeah, I remember we did mix it. I remember using that mixture once, more
Yeah.
maybe once actually. But I'm not sure how I read it. I think because it said 1 ml on the other side, I think I was